Can everybody see my screen?
Yes. Thank you.
Awesome.
It's good, Nick.
Okay, I will get started. So Stacey and I put these slides together. We just have a couple updates for everybody that we thought was important enough to gather the CIDER group together so I can get started. So for a quick overview of what we're going to talk about today, we're going to talk about the multistate STEC outbreak that I'm sure all of you have heard about by now, where most cases are in Colorado. So Colorado is really leading that response with CDC and FDA. We will also go over the active local TB exposure response that we've been doing the past couple of weeks. I believe Chris and/or Stephanie will be co-presenting on that. And then lastly, we'll go over the Marburg response and what we're doing in Boulder County Public Health for that response currently. So first, I'm going to go over the multistate STEC outbreak. So I just want to do a quick overview for STEC for all of you that aren't familiar or want a quick refresher. So it's the only sugar toxin producing E. coli that's reportable in Colorado. So as you all know, there are many different kinds of E. coli. E. coli is very common, but this is the only reportable sugar toxin producing E. coli in Colorado. So these positive test results get automatically reported to us and we are required to investigate them, and especially if there is an outbreak. Symptoms include diarrhea, bloody diarrhea, vomiting, abdominal cramps, and nausea. The primary symptom is diarrhea and/or bloody diarrhea. So keep that in mind for this outbreak. That is the main symptom they're using is that they at least have to have diarrhea. And they could also have these other symptoms, but they at least need to have diarrhea or bloody diarrhea. It's transmitted fecal oral route, so that means it can be transmitted through infected water sources, food contamination, so food sources. It can be also transmitted from animals. So there's many different ways that you can get STEC, but the main route is that fecal oral route. The incubation period is 3 to 4 days on average, but can range from 1 to 2 days. And that's important to note for when we go over this outbreak that's currently happening. And lastly, the infectious period is a little bit tricky for E. coli and STEC compared to our other enteric diseases. So a person can shed STEC in their stool while they have diarrhea, which is common for most enteric diseases, but they can also shed it for a variable amount of time after diarrhea has resolved. So for those of you that are very familiar with our STEC exclusion criteria, it can get very complicated because you have to have those two negative stools 24 hours apart if you're in a high-risk occupation if you have STEC. Next, I'll quickly go over some epidemiology for STEC. So sporadic cases occur throughout the year. Most STEC cases do occur in the summer months. That's our enteric season, as I'm sure a lot of you are very familiar with. And some statistics for Colorado, there were on average 259 cases per year from 2013 to 2018, so pre-pandemic. But in Boulder County specifically, we have more access to our own data. So I was able to calculate it from the past 5 years. So from 2015 to 2023, we had 38 cases per year on average, and that fluctuates. I think our range was from low 30s to around 60 roughly. And then so far in 2024, as of September 31st, from last time I pulled our data, we've had 31 cases of STEC. So now we'll go into more details about the multi-state STEC outbreak that's occurring. So as of October 25th, when we got this last update from CDC, and when you go to the CDC website that's linked below, it also shows that the last update was October 25th. As of today, there have been 75 cases total, 22 hospitalizations, one death, unfortunately, that was in Colorado, but from an older gentleman, and then the likely source right now is slivered onions. That's specific to the quarter pounder. So these slivered onions aren't used on other products at McDonald's. At first they thought it was either the ground beef patty of the quarter pounder or slivered onions, but it seems like the more likely source based on preliminary traceback data from FDA right now is the slivered onions. And Taylor Farms that supplies that slivered onions to these McDonald's locations in these specific states, including Colorado, has initiated a voluntary recall already. And illness onset for our cases range from September 27th to October 10th as of now, so as of 10/25. And I also put a demographic table by CDC. I thought that would be helpful. So you can see the age range is from 13 to 88 years of age. Median age is 29. And for sex, 60% are male. So primarily male, but there isn't a huge difference between male and female, as you can see on this table. As far as race, 95% identify as white in this outbreak, and for ethnicity, 91% identify as non-Hispanic. And this is a epic curve also from CDC that shows when people got sick from illness onset on the x-axis and the number of sick people on the y-axis. So you can see it ranged from, like I said, September 27th to October 10th. And it seems like it may be decreasing, but I do want to note that recent illness may not have yet been reported. It takes a while to get those lab results, and then they also go through whole genome sequencing. So a confirmed case at this time for STEC in this outbreak has to be highly related to the specific outbreak strain and the E. coli strain. And so this isn't the complete picture of all of our E. coli confirmed cases that we currently have. This is just from 1025, so there is that lag in reporting. And then this is a map also on that CDC web link I posted in the earlier slide. And so this shows where the number of cases are currently affecting each state. And so in the blue is the highest number of cases. So Colorado is leading the way currently. And that is partly due to our colleagues at the state health department were able to detect this outbreak before receiving whole genome sequencing results. And so they were ahead of the game on this outbreak, which is great for Colorado. So we'll see if these other states surrounding Colorado will catch up to our case count. And the dark green is a higher number of cases than the light green. So there is a color code legend on the actual website, but it got cut off on my slide, unfortunately. As far as more specifics about the multi-state STEC outbreak in Colorado, so as of last week, there were 26 cases in Colorado that have been included in this outbreak. 8 were hospitalized. Like I said, there was 1 death. The counties involved so far are Arapahoe, Chaffee, El Paso, Gunnison, Larimer, Mesa, Route, Teller, and Weld. And just for you all to know, we may get a Boulder case that stays investigated, but it has to go through that whole genome sequencing. So we won't know if they include that outbreak until later this week or next week. And it's expected that the case count will continue to increase in the coming weeks. Before I pass over to Chris and Stephanie to give an update on the local TB response in Boulder County, does anyone have any questions on the multi-state STEC outbreak? Awesome. Well, if you have questions later on about it, feel free to put in the chat, but I will pass it over to Chris and Stephanie.
Righty. Excellent, Nick. Thank you. Hi, everyone. Again, it's Chris Campbell. I'm the emergency manager with Boulder County Public Health. Just wanted to fill you all in on a response we have with our partners at Denver Health. And this is an active case of TB in a Longmont High School. This has been a partnership with the Denver Health Clinic, the TB Clinic, and Boulder County Public Health. I'll first say before we jump into this that we've just really appreciated the partnership that we've had with the St. Mary Valley School District and the high school we've worked with. The leadership there, the staff have been incredible. And we've really quickly mobilized to really address this concern here. And I'll also say that we about a year ago went through a workshop, a TB workshop with a lot of great partners, maybe some partners that are on this CIDER call. The school district are there, CU was there, and interestingly, we kind of walked through a very similar scenario of a TB concerning TB outbreak that just to talk that through and really to be prepared for something that might happen in our county. So, this case was just so you all know, the case was infectious. We're not clear exactly how long the case was really infectious, but what we did do is we created and got a list of students and looked into how many we should test, and that ended up being we identified about 160 students and staff and faculty that we looked to test, and these were really those that really had pretty close contact, that were likely in a class, we knew were in a class with this student. The good thing, I think, a silver lining is there wasn't a lot of extracurricular activities or things like that we needed to expand this. So really mobilized pretty quickly. And last week, we're able to test with the PPD test or screening about 160 students and staff. We were able to read those last week. So 2 weeks ago, we did testing. Last week, we were able to read those. We did identify about 31 that were reactive, and because 29 of those had the history of having the BCG vaccine, we followed up with subsequent QFT testing or blood test. And out of that, we identified 4 positives with latent TB, and they will receive treatment. Just to kind of clarify a bit of that, so we did 2 of those were verified through the QFT testing, quantiferid testing, and 2 of those were just identified with reading that PPD screen. So we feel pretty good about where we're at generally in identifying a baseline and where things are at with this. We have sent another communication out to the school, all school, to the high school, and the leadership are real comfortable where we're at. We'll do a second round of testing here in December, kind of early December. And really, I think, get a good sense if there's been significant spread or not, but feeling good about where things are at. Since we had this group here, I would just be a reminder of to really look for students that may present with TB symptoms. So as you all do, you communicate well with Boulder County Public Health. And if you happen to see things that are consistent with potential TB, please let us know, let our EPIs know, as you do with all these other reportable diseases. So Stephanie or others, I didn't thank our team. I really wanted to thank our team, the incredible response on the emergency management side, and Carrie Middleton. Stephanie really took the lead on this as well. So it's a good opportunity to jump into a significant communicable disease response with our agency. And I think it's, just shows that, we're take these things, we really mobilize around these things and work with our partners to really protect public health. So I just want to thank everyone for that. Any questions from the group? Anything I missed? Go ahead, Stephanie.
I was just going to say, I think one of the things that was really remarkable also was that we identified about 180 students and staff. We had, I think, only maybe 10 who we weren't able to get consent and test on. So it was a really good sample size as well. And then we were able to, get everybody read, I think, except for 2, again, which was just a remarkable response. And the families and the staff, like you said, really came together and helped us out to get those kids and that staff tested.
Yeah, Sophia as well for your partnership on this. Much appreciated. Okay, I'll turn it back over to you, Carol, unless there's any questions from the group.
Thank you so much. Thank you for that summary, and of course, thank you, Sophia Yeager, too, over at St. Vrain, who so promptly reported, and it's been so great to have Stephanie, who was with BVSD prior to joining us at Public Health. So I think all the stars aligned for a really great response. So thank you, everyone.
Yeah, I just wanted to say, I wish the health clerk from Skyline could be here, because that guy should be an emergency preparedness person. I mean, he was so organized. And anyhow, yeah, I wish Logan could be here, because he was a rock star and kind of the MVP.
Wonderful. Thank you, Sophia. Kudos to Logan at St. Vrain. Thank you so much. For a smooth response. It it's a heavy lift to go through this type of response. So great work, everyone. Thank you. So now we're gonna jump in to the final portion of the Marburg outbreak. And thank you, Nick, for putting these slides together. And I'll pass it back to Nick and to give us the overview, and then we can jump in with discussion.
Thanks, Carol. So let's get into the Marburg outbreak. And it seems like most of you would be aware of this on the call as well. But gonna give a quick Marburg virus disease overview, just as a refresher. So it is a rare severe viral hemorrhagic fever, so it's in the same family as Ebola. Symptoms include febrile illness, rash with both flat and raised bumps, chest pain, sore throat, nausea, vomiting, and diarrhea. The primary symptoms to look out for would be a fever and rash. And then more severe symptoms as the virus progresses would be liver failure, delirium, shock, bleeding, and multi-organ dysfunction. The incubation period is 2 to 21 days, so it's a pretty wide range. Transmission can be from animal to person, so the reservoir is a specific type of bat, but it can also be from person to person as well once it spills over. And the fatality rate is 20 to 90%. And so that's why we're taking this very seriously, as well as the state and CDC, to monitor travelers coming from that outbreak location, which is currently in Rwanda. And before we get into the specific outbreak in Rwanda that's currently occurring, this is just a map from CDC of the recent Marburg outbreaks. So you can see the distribution is mostly on the African continent. There have been some outbreaks in Europe as well, and specifically Germany and Syria, but most of these outbreaks are in sub-Saharan Africa. So for the 2024 Marburg outbreak, like I said, it is currently in the Republic of Rwanda. This outbreak was first detected at the end of September 2024, so fairly recent. And as of October 24th, which is the last time CDC has updated these numbers, Rwanda has recorded 64 illnesses and 15 deaths from Marburg. Most people infected are healthcare workers, specifically those working in intensive care units. There have been no reported cases of Marburg in the US. And traveler screening in the US began October 16th, 2024. And the airports that these travelers are being screened at are JFK, New York, Chicago O'Hare, and Washington Dulles International Airport. So those are the three main airports that travelers from Rwanda are being sent to for initial screening by CDC. And then from there, from those coming to Denver, they will be traveling to Denver. And there have been so far no travelers in Boulder County. There have been a couple identified in Denver County, but none in Boulder or other counties at this time. So as far as what we're doing for preparedness and response, so we're reviewing our travel monitoring SOPs that CDPHE has created for instances like this. I know this SOP was followed for a similar travel monitoring response for Ebola some years ago. And for any travelers that the state is notified of by CDC that need to be followed up with, they will then notify us, and we'll do some case investigation with that traveler or travelers in 21-day monitoring period. And then if we are monitoring any of these travelers and they report symptoms and they need to go to a healthcare facility, we would notify that healthcare facility and talk to them about it before that traveler comes in, just to make sure the proper precautions are in place and PPE, so none of the healthcare staff get infected, since they're the most at-risk group for Marburg infections. Does anyone have any questions about the Marburg outbreak in Rwanda, our response and preparedness that we're currently initiating, or the state's response and preparedness, in case we get some ill travelers in Boulder County? Yes, Colleen.
Hey, Nick. Everyone on this call knows that viral hemorrhagic fevers are are the scariest thing in the world to me, even though I live in the middle of Colorado. But Yes, I have a question. Obviously, there's that risk to healthcare workers. If there are people who arrive on a plane, then are they notifying the rest of the passengers on their plane? Is that not really a concern? Like, what does that look like?
Yeah, so that is a great question. If a traveler from Rwanda is on a plane and they come down with symptoms on that plane, they are asked to report that to the flight attendants. And then when they land, since CDC is doing that initial screening anyways, then CDC will be notified before they land so they would be prepared for those ill travelers. If they aren't ill, then they won't need to tell anyone on that plane, but CDC will still do an initial screening with them when they land to ensure that they don't have any symptoms. So either way, ill or asymptomatic or symptomatic, they will get that screening when they land in either of those three major airports by CDC staff. But if they are ill, they are asked to tell a flight attendant. And from there, from past responses like this, the travelers that are identified as in that risk group that sit near that person will then also most likely be monitored or contacted. I'm not sure where Boulder County and our staff will be involved in that part of the response, but CDC would be monitoring that as well. And Carol, it sounds like you want to jump in with some more information.
Yeah, yeah, I did just want to share that it looks like the Marburg outbreak in Rwanda has been um, winding down, although I don't know for sure, but the outbreak is 5 weeks in, and the majority of cases occurred in the first 3 weeks, and in the fourth and fifth week, there's only been one case in the fourth week and two in the fifth week. So we're in the sixth week of this outbreak right now, and I think they've had really strong response on the ground in Rwanda. And it looks like they have travel monitoring in place in Rwanda as well, where they're screening all international travelers for symptoms at departure, and they're also not allowing international travel for 21 days for any close contacts of the known cases. So there is, you know, quarantine happening in Rwanda too. So we did hear from CDPHE that 3 returned travelers are being monitored. Other jurisdictions, not Boulder, but they were all very low risk. So I think that the likelihood from this one is really low or becoming lower, hopefully. But I do also think it's always good to dust off those procedures, like we mentioned, because like this outbreak, it's like known and we were able to activate, but the difficult ones are when things just slip through the international borders when we're not ready, right? And so just having everything dusted off is always good to have it prepared. But I was wondering if facilities, I know that we had a viral hemorrhagic fever exercise last fall with one of our hospital facilities, and that was super fun and great to see on the ground. But I was wondering how other facilities are feeling with their preparedness for receiving or having a traveler with that, you know, may have viral hemorrhagic fever from an international outbreak. I don't know how different facilities might be feeling, and I know we also have folks with our transport partners as well. And I see Chris with AMR, and I know that if we're monitoring a traveler, we would definitely be doing that education, making sure that those notifications happen, like this person is coming from a zone or something, so that we know that all that communication is in place if they were to need transport or medical care.
I guess I do have a question. Is there do we already have any kind of like agreement in process for if you guys want to move somebody that we know has a specific, if we have a confirmed person that we want to monitor?
do we, what, if we are getting we would get notified if there's a traveler, but then, was your question about transport or where they would get care?
Well, so like, let's say like if somebody was identified, would the county contact AMR or would that be a 911 call, or how would that process be initiated if there was someone that you guys determined needed to be, further assessed from the community?
Yeah, if it were to be a 911 call, because if we're working with a traveler and then they develop symptoms and they feel they need emergency care, we're not going to tell them call us first. We would say call 911 first, but tell 911 the status and the situation, and make sure that information is in place. Um, and I don't know if Dr. Belknap has joined us yet. He said he would join us around 12:30. But one thing that is important that Dr. Belknap shared is that if we have return travelers who we're monitoring, the likelihood of them developing symptoms, it's likely going to be something that's circulating. Like right now, respiratory season just started, so it's more likely to be flu or COVID or something other than viral hemorrhagic fever, and in our return travelers. So we do want to establish good triage and planning and understanding of the care and follow-up that we would want to provide for any of the travelers we may be monitoring. And so we would, on our end, immediately loop in Dr. Belknap, of course, to help with that triage and decision-making process. And we would also try to identify with any return travelers, what is their usual medical home when it comes to emergency room or their geographic location for emergency transport and all these things, and have those conversations on the front end, and keep those queue things up so we know what we would need to do. But I do think that with this situation, the likelihood is super duper duper low, because the outbreak seems to be winding down, and because of the restrictions in place in Rwanda, where any close contacts would be kept in country for 21 days. And that, I don't think that was the case back in Ebola. I don't think that there was travel restrictions in place. I know different organizations may have had different monitoring, but we had a lot of people that we monitored during the Ebola outbreak. I think maybe because Boulder County might just have a higher per capita of people who work for organizations like Doctors Without Borders and whatnot. But yeah, those are the thoughts. But yeah. I think it's Kelsey, I think, right? Wasn't it your hospital that did the viral hemorrhagic fever exercise last fall? I think. Yeah.
I am actually new to Good
Yeah.
With my second week. Oh, Amazon.
Yeah, I was there at that time, and it was really nice to have Boulder County there as well to help us identify some of our gaps and improve.
Great. Cool. Well, I don't think, I don't know if Bob, our CMO, was able to join us. But I don't know if anyone has any additional questions. What I wanted to loop in Bob for was that Denver Health, where he works, is a designated regional biocontainment unit for us here in Colorado and many other states. But we wouldn't necessarily, oh, there's Bob. Perfect. You appeared. It's like I summoned you. We were just gonna start sharing some information about Denver Health and the designation as a biocontainment unit. But we did also mention that probability of people who are monitored travelers are more likely going to be developing symptoms that are flu or COVID and not necessarily viral hemorrhagic fever. So we want to think those pieces through. But any thoughts you want to share or any experiences from the biocontainment unit, we'd love to hear.
Yeah, thanks. So you're correct. That so at Denver Health we have the biocontainment unit for the state and potentially beyond. It's a regional resource if needed. The activation of that would happen through a process that would a process of decision making that would include CDPHE, the CDC, and the leadership of the BCU. So it's not a process where someone has traveled and now they're sick and now they walk into Denver Health or come in and they're immediately go to the biocontainment unit. Uh, it's the commonest scenario would be in a situation where someone is being monitored. If they develop symptoms, then the first step is to contact CDPHE and sort of talk through the risk history in terms of where that person traveled and what they did while they were traveling, along with the symptom history, and determine from there if the person needed to be tested for viral hemorrhagic fever. The examples to date, so going back a few years ago when there was the Ebola outbreak in Sudan, and then till now with the current Marburg outbreak, when they have had people that they've been monitoring, there's not been anyone that met that threshold where they had high enough risk exposure or likely exposure based on travel and symptoms to where they needed to be tested. So the decisions have always been, no, this is unlikely. So what is far more likely is that someone with lower risk of exposure, but who has traveled, and in the 21-day period of monitoring, they develop mild symptoms of some sort, headaches, fevers, or otherwise. And so in those cases, it's going to be what the CDPHE says, and I think appropriately so, is that they're not going to be the ones giving medical advice to individuals, and that's for us and local public health agencies, it's a somewhat of a challenge as well. I think as a medical officer for Boulder, it may be a space where maybe I could help support in talking through with someone about that. Ultimately, it's going to be the individuals, how they feel, and if they are concerned and they need to seek medical attention, we would not ever tell someone not to seek medical attention. But then it becomes, taking the information we have and making folks available. So if they were going to go and seek care, calling ahead of time and having that conversation that says, this is this scenario. This person has a history of travel. They're not high risk, because I don't think this would be someone in a high risk situation. They are having some symptoms. They need and they were wanting to come in for an evaluation. And here are some steps that you could do to be cautious. But really, you should be looking for things like flu and COVID, or dengue, malaria, depending on where they traveled. Looking for other things. So that's sort of the real quick version of things. And CDPHE does have great resources on their website for viral hemorrhagic fever, and link to Marburg with outlining steps in different steps in the process and trainings available.
Absolutely, thank you. And we had just mentioned with Emma and Kelsey that their facility did do a large scale full exercise with actors and everything last fall, and it was great. And so I guess if we have a return traveler who develops symptoms, it could be used as a, hey, let's run through that response. And they likely only have COVID, but we could just do all the donning and doffing and all the things that we want to exercise anyway and whatnot. Could be that way, but definitely we would keep those communication channels open. Okay. Thank you. Well, are there any other thoughts or any other facilities to share their questions or any other information? Yeah. Great. Okay. Well, we just want to thank everyone. Thank you, Nick, for preparing the presentations, and Stephanie and Chris and everyone for the TB response, and Bob also helping us on that TB response that that we presented on earlier. And thank you everyone for all that you do to keep our community safe and healthy, and for coming together on the CIDER call. And hopefully we won't be meeting too frequently, because we'll always be reconvening whenever we have something that pops up. But hopefully it won't be as frequently as we met during COVID. But we also, don't be strangers. We're here to work with you. So thank you, everybody. All right.
Thanks, Carol. This is
Thanks
great.
all.
Thank you. Bye.
All right. Bye.